Okay. Oops. Oh, there we go. Okay, so I'm going to be talking. So first, just to introduce myself, I'm Erica Sood. As Erin mentioned, I am a senior research scientist and pediatric psychologist at Nemours. And it is accurate that I grew up in the really in the Excel program, and also now have funding through the Reach Cobri. Um, and so we're going into our third year, and did submit an R1. So hoping that at some point I will graduate from the Reach Center and move on to independent funding. So I'm going to be talking about some of the work that has kind of led to where I am now. The user-centered development of HEARTPrep, which is a digital health psychosocial intervention for prenatally diagnosed congenital heart disease. So for those of you who are not familiar with CHD, it is the most common birth defect, affecting about 1% of births, and about 25% of those born with congenital heart disease require intensive care and cardiac surgery in the first weeks or months of life, in some cases the first hours or days. And this involves separation from parents at birth, emergent admissions to the intensive care unit, invasive procedures like cardiac surgeries, long hospitalizations, and complex healthcare navigation at a time when we really would like, instead for there to be a lot of parent-infant bonding and closeness, and it's a really sensitive time for infant development. So congenital heart disease increasingly is diagnosed prenatally around 20 weeks gestation, and prenatal diagnosis has clear benefits for delivery planning and birth outcomes. And so the goal is for more and more babies to be diagnosed prenatally. However, it does exert a substantial negative impact on the mental health and well-being of expectant mothers who find out during pregnancy that their baby will be born with a life-threatening heart condition. And we know that mental health is a vulnerable time. Pregnancy is a vulnerable time for mental health. So among women carrying a healthy fetus, we see rates of depression and anxiety and stress that are about 10 to 25%, so very high. Mental health problems are considered to be the most common complication of pregnancy and childbirth. However, when a fetus is diagnosed with congenital heart disease, those rates double or even triple. And we also see high rates of traumatic stress associated with finding out during pregnancy that your baby will be born with a life-threatening heart condition. We know that maternal mental health during pregnancy affects child outcomes. So prenatal mental health problems are the strongest predictor of postpartum mental health problems, and postpartum depression and anxiety is known to affect bonding, maternal-infant interaction quality, parenting style, as well as child developmental and behavioral trajectories. But in the context of congenital heart disease, there's extreme stress during the postpartum period that can exacerbate these existing mental health issues. And this can lead to long-term parent anxiety, depression, and traumatic stress, which we do see in this population, and ultimately contribute to child developmental, emotional, behavioral problems, which we also see in this population. So about 50% of children with congenital heart disease are at increased risk for experience some type of developmental delay or disorder. And while there are many, many factors that contribute to this, the opportunity to kind of promote maternal and family well-being is an opportunity for neuroprotection. And we know that parents want psychosocial intervention after a prenatal diagnosis of congenital heart disease. So my early work this was actually funded by the Menda Heart Foundation, which is a grant that I got from having an MRDA through the Excel program. But we looked at what parents want in terms of support and intervention. And we asked many questions about, the types of intervention they want, who should be delivering it, where it should happen, in what format. But we also asked about timing. And of those that had received a prenatal diagnosis, 88% of mothers and 80% of fathers felt this would really be the ideal time to start psychosocial intervention, because they were sort of in preparation mode, anticipation mode. They were getting a lot of good information about the medical aspects of congenital heart disease, but really no information about how to prepare for this emotionally and the impact that this would have on their family. So this led to the user-centered development of HEARTPrep. And we developed HEARTPrep in 5 phases. So I'm going to just go through very briefly the 5 phases that we used. And this is based upon existing models of intervention development, but we adapted for this particular intervention, and also really focused on kind of partnerships with design and technology experts as well. So the first phase was to co-design the intervention with parents and clinicians. So we knew that we wanted to develop an intervention that would take place during the pregnancy after a prenatal diagnosis of congenital heart disease and promote long-term maternal, family, child well-being. But we didn't know how to actually do that. And so we recruited parents across 8 health systems that were in the PedsNet Clinical Research Network. We worked with 8 clinician partners across the network that helped us to conduct the research, but also to recruit the participants. And we also identified 4 parent research partners across those 8 institutions. So the parent participants were English or Spanish speaking, and they had all received a diagnosis of congenital heart disease during pregnancy in the last 5 years. We used online crowdsourcing to collect data from our parent participants. And this refers to the process of generating ideas, solving problems, and producing results by soliciting contributions from large groups in the form of online communities. We did this using a platform called DE-INBRE, posted questions, and people could respond. They could see each other's responses. They could reply to each other's responses. We did this across 5 phases of data collection. I don't have time to go through each of these. I have published on this if you're interested. But we really started from what do parents actually want in terms of goals? Like, what do we actually need to affect during the pregnancy in order to promote long-term outcomes? And then what actually needs to happen, right? Like, what do we need to do? Not just what are we targeting, but then what do we do to target those outcomes during the pregnancy? How do we deliver it so that people will actually use it and find it to be acceptable? And then we got stakeholder input on the design itself and even had stakeholder input on the selection of our outcome measures. This resulted in the design of HEARTPrep. So at this point, it wasn't created yet, but we had an idea in mind of what we wanted to develop. And so we decided that we wanted to develop a modular intervention. Module 1 would be focusing on kind of that initial adjustment to the prenatal diagnosis. Module 2 would be focused on kind of social relationships and connection with the social network, sort of new and existing social networks. And then module 3 would be focusing on primarily emotional preparation for the birth of the baby and what they would experience in terms of stressors after the birth. All of these have kind of the secondary goal of increasing hope. And we identified 6 HEARTPrep elements: normalizing and processing emotions, developing coping skills, engaging a supportive network, connecting with peer support, accessing resources that already existed but are really hard to find during the stressful time, and supporting the role of cultural beliefs and faith for adjustment and coping. And based on the input from our parent partners and participants, we decided to deliver this intervention through mobile app with telehealth sessions and sort of online kind of app-based modules that included videos of experienced parents sharing their experiences, articles with tips and tools for coping, and links to trusted resources in the community. So then the next step was to develop the initial prototype. So we knew what we wanted to design, but obviously putting that into an actual kind of format of what it would look like is a big process. So we got input from researchers and members of the Nemours Center for Health Delivery Innovation who were working with us to develop this within the Nemours app, from 2 mothers of infants with congenital heart disease, and this informed the development of a testable intervention. So just to show you what this looks like, this was the initial prototype. So this was really done on really like a Word document or a PDF where things could just be moved around. But to give us a sense of what it would look like, how it could be structured, where the text would fall, we then got feedback from different stakeholders at this level. And they gave feedback primarily on the content and things that needed to be added. Once we had their feedback and we felt comfortable with what we were proposing, this was then built within the Nemours app into a test environment, basically. So it wasn't live yet, but we could access it through a test environment. This is what some of the articles look like. We then conducted Think Aloud testing, which is a process of having, in this case, parents navigate through the app and through the modules without a lot of instruction. And so really what they would be doing at home, right? Like we told them the general gist of what we were trying to do. We showed them how to get into it because we would do that during the intervention, during the telehealth sessions. We do kind of explain how to access these materials. But once they were in HEARTPrep, or in a module, they went through it themselves and talked out loud what they were thinking and experiencing. And through this process, we were able to identify a number of issues. So difficulties navigating between articles. We had put direct links from one article to the next, but then you kind of get lost and you don't know how to get back to the home page. We had to remove those. There was the link to the trusted resources was at the bottom, and it said find help and support. People thought it was an IT kind of help center for the app, or a message center, and so nobody clicked on it. So when we asked why they didn't click on it, we learned that it was really misleading where it was positioned, and also, kind of what the title was and what the description was. People suggested adding and removing content, wording changes for clarity, things that we kind of suggested in terms of coping skills, that they were like, nobody will ever do that. Take that out. And so we were able to really ensure that this intervention within the Nemours app was usable, acceptable, and hopefully also feasible for families, for users. We then conducted beta testing with 10 families. So this was really, conducting the intervention as we would in the real world environment, to determine kind of usability of this intervention. And what we found was that everybody accessed module 1, and all 10 participants accessed 9 of the 10 accessed all of the resources. One missed one article. Module 2, the majority accessed. We had one who did not. And then module 3, unfortunately, we had 2 parents who delivered just before they could be assigned module 3. So they delivered before their scheduled date. And so we learned from this that one of our biggest barriers here is that we have this really time-limited period that ends with the birth of the baby, and we can't always control exactly when that is. So we really do need to ensure that we start the intervention by 30 weeks gestation, with the goal of ending by 36 weeks gestation at the latest, so that we can collect the post-intervention measures and not kind of lose people based on delivering the baby. We also got feedback on acceptability. We had them fill out an acceptability survey, and as you can see, acceptability ratings were quite high, and people really liked being able to access the intervention on their phone from anywhere, at any time, and to be able to participate in sessions using telehealth. We are now in the process of conducting pilot testing with looking at our clinical outcomes. And so we have measured depression scores before and after intervention. We also have some weekly data that we haven't looked at yet. But what we're finding is that we are seeing in this pilot a decrease in depression, maternal depression from pre to post intervention, and a decrease, but smaller decrease in anxiety from pre to post intervention. And this as we've kind of gotten more experience conducting this intervention, is not unexpected, because as you get closer to giving birth to a baby with a life-threatening heart condition, knowing that that baby's going to be separated from you at birth and go into the intensive care unit and need heart surgery, it is an anxiety-provoking situation, and that is sort of normal. And so we probably can't expect, although we would wish that we could totally reduce anxiety. We don't know how feasible it is when anxiety is kind of a normative experience in this process. But we are encouraged by these results. So in terms of next steps, we will be evaluating the impact on maternal mental health and well-being during and after pregnancy, evaluating the impact on postnatal clinical outcomes, including maternal-infant interaction quality, developing strategies to reduce any inequities in engagement or outcomes. And then long-term, after the proposed R01, hopefully if that's funded, this intervention model could be adapted to other birth defects, which make up 3% of all births, and there are not currently existing psychosocial interventions for mothers expecting a baby with a birth defect. Thank you very much. Happy to kind of take questions or answer anything.